Good evening, Kat. It exposed our health system truly. What is our people's needs and where the health system stands. And it taught us many lessons. And coronavirus, we have to thank. Polio virus taught us during our polio eradication who is the unraised and the marginalized whom we should focus. Coronavirus taught what we need to do in the health system. It exposed the vulnerability and fragility of our public health system. It is not something surprising. It is a cumulative neglect for decades in underfunding, uh, understaffing, and it is poor infrastructure and the need for technology upgradation in many places. Uh, Resulting, all these neglect had resulted in dismembering of the system and almost to an annihilation or standstill in various parts of India. It, but all the same, it is needed. It proved its relevance and essentiality of this system because the nation needs it. And nation means about 40% of the absolute poor and with a lot of middle class people. And the nation needs it with an immediate upgrade because it is the only option for the poor and the marginalized. And we cannot think of dismantling it or go for alternatives. Private sector we can't rely upon. They have exposed themselves, they were shut down, and they closed their gates during this pandemic. In any pandemic or a crisis, there will be a lot of inadequate preparedness. Whole world was not prepared for this outbreak of this virus. There were a lot of errors in decision making and a delay in decision making, and there were a lot of wrong strategies. Mistakes are made in implementation. WHO made mistakes. WHO said initially only droplet infection and formites and hand washing and sanitizer use and all will be good enough. But by June 2020, there came a lot of evidence came about aerosol transmission, and finally WHO corrected it and they said use of mask is very important. But all these mistakes are pardonable. It is part of the learning process. The virus is new, the treatment methodologies were new, we were figuring it out. So, but learning, and it is part of the learning and the growth. But refusal to learn from mistakes, that is a tragedy. That's a tragedy for the future generation. And what lesson we have learned is science is never perfect. Science grows by advancing day by day. And science should prevail, not politics. Politics is based on opinions. And if you have to make political decisions to govern us, that should be in a calamity like a pandemic. It should be strongly guided by technical advisors, sound scientific principles, and technical advisory bodies should feed into government orders and political decisions. Best of brains should concur, not a favored group of, and that group hatching surprise declaration. Nobody is going to get impressed by surprise decisions. Now, what are the lessons learned? In February, we should have closed all the airports because the virus coming to India is an imported virus. Virus is a foreign virus. It is coming through airports, and those who can afford air tickets. And it came from Wuhan, it came from Saudi Arabia, it came from Iran, pilgrims, and many people all through airports. So we should have known where the virus goes. We didn't do. There is a pathetic lethargy in active screening and monitored home quarantine and domiciliary isolation of positive cases and active contact tracing. We didn't do that in the entire month of. We slept over it, and there were other priorities in the country, and unfortunately, and whatever it is, I'm not going into what that historical scenario in February and early March in India that was taking place. And there is all of a sudden, March 23rd, an abrupt national lockdown. It was not guided technical decision based on any epidemiological evidence of or virus transmission in a huge country like India with 736 districts, only 75 districts had the virus implanted, and in 3 major states, Delhi, Maharashtra, and Kerala. So this unnecessary lockdown of the whole country was not justified. That was the first. Second mistake we did. There was unnecessary locking up of migrant workers and urban poor in their settlements, and that was in a fertile ground for this virus and virus that came from abroad. It is not a virus originated among the urban poor or the migrant workers to multiply. It was a petri dish where the culture was made. The other lesson learned is we can't get a pandemic control which is enforced, police enforced or administration enforced. We can't. There is a community involved, system official, a community rather than system officials. We can, for COVID surveillance and COVID appropriate behavior enforcement works better. We have seen it in Dharavi slum, where one Mumbai corporation office bearer went into all the house to house and made community-based or slum-based planning. And that is also the lesson of Kerala, how that all 14 districts have the district committees down to 956 gram panchayats and about 65 municipal bodies making plans. The other thing is, in a pandemic, though we are dealing with a virus, but we are not virus and its after effect, the human element is very important. Addressing hunger is so important, and cash transfer for purchasing essential things to survive is so crucial in a lockdown, if lockdown is the methodology what we have adopted. And that is where the Kerala's example of running community kitchens, giving dry ration kits, and running Janata hotels for subsidized food all became an excellent example of how to deal and address hunger in a pandemic. Then another mistake what we need is closing the regular services. It is inhuman to stop regular services for maternity, medical and surgical emergencies, curative care of acute illnesses, blood transfusion for thalassemia patients or cancer patients or those who are aplastic anemia patients, chemotherapy for cancer patients. This is they cannot stop. They cannot stop. It is so inhuman. Kidwai Cancer Regional Cancer Research shut its gate for cancer patients for the priority given to coronavirus. That cannot be done. Another equally burning bacteria, tuberculosis bacteria or malarial parasite. We can't in India, where tuberculosis kills more than 1 lakh people. Tuberculosis or malaria, we cannot shut our eyes. Stop. We'll deal with it tomorrow. We cannot lose the advantages and advances we made in HIV/AIDS control because of corona. Other thing is, if there is an epidemic, we need alternative arrangements. We need beyond what the regular system can absorb. We found that we need dedicated COVID hospitals because it's highly contagious or transmissible. So we need separate hospitals, we need separate ICU and civil COVID isolation hospitals and community-based quarantine centers. So what we found is that the health system, which is not static, which needs a resilience, which is strong, but it needs an elasticity. It needs a mobility. So it is an elasticity. One day the need is so much, the next day the need is less. So it could be pulled and elastic, and it could be multi-located, quickly moving, like a foot of an amoeba. You all studied some basic basic zoology or biology. An amoeba unicellular organ moves with the legs reaching out to some directions it wants to move. Same way, we need alternative arrangements to ramp up our capacity at short notice and meet the surge and quickly come back or roll down or dismantle as soon as the need is over. Karnataka had, for example, Karnataka had a good setup of, they were very confident 740 ventilator supported beds are there in March, and government and private sector. In double than the public sector, in private sector, a lot of five-star hospitals, and there were only 2% occupancy till first week of May. And everybody thought it is a lot of unnecessary hue and cry. What is the need of it? But by July end, August, September, there was shortage of beds. There were same thing in a national scenario. We had 27,000 beds in India, and Health Minister was very proud, and we had only 4% occupancy. We are well under control. But quickly the scenario changed in August, September, and Delhi was suffocating. Lack of oxygen, lack of beds, and people are running helter-skelter. In January 21, Delhi reduced, end of 2020 and early January, Delhi administration reduced the COVID beds to 5,000, and because bed occupancy was less. And but by nobody expected, suddenly March, April, the cases went up, and then 90% occupancy, no oxygen. It all overwhelmed in May with added oxygen shortage. So what we need an elastic system, how it can be responding. We need, so what can be moved? Naturally, the hospital and big aims and the Safdarjung hospital, we cannot move. So it is immovable structures and equipments we cannot move. But whatever is movable can be moved. So we have to train staff, some equipment, some ventilators, medical supplies, they can be moved across the districts and states. And we have got good example. Minister Gadkari has requested for Nagpur area ventilators from Andhra Pradesh, which they obliged, oxygen from Odisha, the state obliged. And the other movable thing is, if you, big institution, you move the patients where there is a high caseload to places where their institutions are. You cannot say, oh, Delhi is for Delhiites. So adjacent districts of UP, Punjab, Haryana, and Rajasthan, patients flock to Delhi. So that is part also of the need. Another lesson learned is wealthy cities may not be the healthy cities. Mumbai definitely proved, Pune, Delhi, all are examples. Calcutta, as it is, the infrastructure wasn't good, that also proved. A weak public health system can make the life miserable, especially where it pinches is the urban poor. And equally, but those urban poor, it is not that somebody is doing a charity for them. Like migrant laborers are 37 to 40% of the population. They are builders of Indian economy, but they are the least enumerated, accounted for, or planned for. And you see, if there is a virus implanted in it, the whole city is in danger. So if you are doing anything by improving the health standards of these poor people, are not doing a charity, you are doing in your own self-interest. So think about that. Provisions of basic services like water, sanitation, and clean night shelter and drainage and temporary of the dwellings for them. It is good for everybody's health. Another lessons what we learned is in how small is in floods or earthquakes or cyclones, we need in every habitations or human community, there should be some safe areas for earthquakes. And that could be a community center. It can be used for community meetings, social events, and also for relocation, running relief camps. And I've seen these type of community centers built by community governing bodies like Gram Panchayat in Bishnupur district, in Manipur and places like that. Many places I've seen. That's a good thing. Now, in we had the huge pandemic control. We had the service about 9 lakh women. They're called ASHA workers. They're supposed to be voluntary, but it is voluntary is a term of highly exploitative term to overcome the requirements because of the prevailing labor laws. But they were the backbone of our entire surveillance activity in the community, contact tracing, getting suspect tested, quarantine of the family members, isolation, clinically asymptomatic positives to be separated, and reverse quarantine of vulnerables and especially the elderly public during the pandemic. Now, my question is, if ASHAs are inevitable, intermediary between health officials and the community, accept them as a regular contributor to the India's health system, pay them the right wages, and get that funds be spent from National Health Mission. That is one way of spending usefully increased budget allocation for public health system. Currently, there are 275,000 contractual workers. That is a misleading term. They are consultants, technical hands, regularize them. That's I think. I'll go to two recommendations at state level and national level. Now, state level, every state, telemedicine as a regular modality for can replace a lot of personal consultation, trip to hospitals and all. So do it as a regularized behavior post-COVID in the non-communicable diseases and control of other illnesses, mental illnesses, and palliative treatment, etc. Now there was only one national virology lab to conduct to diagnose coronavirus initially. From there, it is now so many labs have come up. So every state to have a regional virology research lab, and that could be also a co-production center for vaccine of newly evolving viruses. We don't know now. Zika, the first case in India has been reported after many years. The first case in Surat, now the case in Kerala is reported. Now, what we don't know. So we need a vaccine production units as well as virology research labs in every state. We need oxygen shortages. We could have had oxygen factories in every state. And from this oxygen in medical oxygen production centers, we need to move oxygen in tankers and that immediate supply of liquid medical oxygen. The irony is all our oxygen production are all where the steel plants are there and coal and steel is used, like Odisha, coastal Andhra Pradesh, and places like that. And we need oxygen up in Haryana and Bihar, and Bihar, at least the oxygen production to some extent is taking place. So we need the oxygen transportation quickly. Now, another thing is state to have a communicable disease control center, like a national communicable disease center to coordinate effect. What we lacked in the last epidemic is the pivotal role or leadership role by two agencies, the National Center for Disease Control and ICMR, to take the lead. Their technical advisors were overshadowed by political considerations or whatnot, who made the decision. Some blunders were made. There is no uniform treatment guidelines, consensus building, all these things were lacking. Even now, some of the consensus building on COVID management, probably Dr. Naveen Shah will refer to that, how it is done in United States. So that is lacking. And we need to do that at a state level and national level. We need enforcement of Clinical Establishment Act and regulation of private sector. We can pay the money, whatever the treatment, but exploitative extraction of money and billing should be stopped. That's why the court intervened in reserving ICU beds in private hospitals in Bangalore, Karnataka High Court. Kerala High Court intervened in pricing of the PP kits and per day charges for ICU care and detailed billing. So we need to do that. Another lesson learned, at least from Kerala, is that transfer a part of the development fund to the local self-government, well, municipal corporations and town municipalities and gram panchayats in planning, delivery, and monitoring of health services under them, including disease outbreak control. At district level, probably this is my last slide. District level, the most important thing is do the categorization of districts where the pandemic is high, heavy, or very minuscule, like occasion. And districts, every district, those districts which do not have a medical college must be having a district hospital, which will be the tertiary, the apex center for the full tertiary care. So it must have, just like a medical college hospital, it should be equipped in all care, like burns unit to plastic surgery to dialysis unit, cancer therapy, everything, every component of a medical college should be there in a smaller fashion to meeting the population demand. Then you need these tertiary care institutions are not also can be you can prioritize it. There should be a spatial equity of tertiary care institution in the country. For example, even in this pandemic, 45 districts were contributing to 50% of the corona caseload and severity of cases. 145 districts contributing to 75% of cases. And so they need a saturation, more saturation of equipment investment, staff deployment, everything, depending on what. Later on, then you can dismantle. So you need special equity of tertiary care in those districts which have got high caseload. That is a flexible plan. And every district hospital to have a 50-bed isolation ward for communicable disease, and with 10 beds will be for ICU beds. And a minimum of 5 ventilator beds for respiratory support, or maybe dialysis units. All these things, you can fix a minimum number essential for life support. That has to be full-fledged, not like 4 or 5 districts absolutely neglected. Then 2 adjacent districts have got everything. That should be, that iniquity should be disappearing. Then the one good example Kerala has done, in all 14 districts has got a liquid medical oxygen generation plant of 150 tons production capacity. This can be done and replicated in all the districts in the country. One very, very important thing in pandemic control is the accuracy of data. Now, lot of responsibilities and accountability is passed on. They say, I'm not responsible. There should be a full responsibility and accountability fixed on district magistrate and chief medical officer for data, what they get from their own system, triangulate with other events, like the journalists expose, what is the number of deaths that and dead bodies cremated, and what is buried in the burial grounds, that register, that doesn't tally with the number of deaths reported by the system, and it doesn't tally with the civil registration system. That certificate got exposed, and that is why a series of data points that the Hindu newspaper has exposed. So there is a increase in death. Where is it? Who owns the responsibility of declaring the accuracy of data? Because in a pandemic, those epidemiological data is so important for forecasting what could be the action forward. Then I would say we must have a float assembly of reserve medical staff, of public medical staff, which is deployable at short notice and dismantleable. And how is it? Where do you get that reserve medical staff? They can be from private sector, they can be public sector hospitals, interns, PGs, nursing school final years, and you must have that. And you can have like voluntary blood donors list. They are ready to be called and immediately retired. Last 3 years or 5, within last 3 years, 5 years, who are retired, you can get. And I will end here. Maybe we can take up in questions. Thank you.